Good morning. It's my pleasure today to speak about what's new regarding calcineurin inhibitors and mTOR inhibitors. And it is my honor and pleasure to have the same title to be presented within the activities of the annual conference of Egyptian Sotic Nephrology and Transplantation within the coming days. So I'm starting with the outline. I'm going to start with the introduction, followed by the most important, the most difficult sector, which is pharmacokinetics, drug interactions, and monitoring of calcium inhibitors, followed by adverse effects, post-transplant diabetes, hypertension and cardiovascular complication, nephrotoxicity and electrolyte disturbance, and some special situation related to calcium inhibitor use. Then different trials and special situation for the mTOR inhibitors, and I'll end with closing. So let me to start with this slide. Both calcium inhibitors, cyclosporin and tacrolimus, were introduced since a long time. Cyclosporin was introduced in the 80s on 1983 and tacrolimus on 1994. And regarding mTOR inhibitors, sirolimus was introduced in 1999 and everolimus in 2009. Regarding their use within the scientific registry of transplant recipients within the United States, as you see, cyclosporin is vanishing as primary immune suppressive drug, and it is almostly replaced by tacrolimus in adult kidney transplant recipient. And the same scenario within pediatric kidney transplant recipients, tacrolimus replaces cyclosporin. And the Renal Association guidelines stated that they recommended the maintenance immune suppression should normally consist of a calcium inhibitor and anti-proliferative agent with or without corticosteroid in low and medium immunological risk kidney transplant recipients. And the majority of calcium inhibitors are tacrolimus. In our center at Virology and Nephrology Center, Mansoura University, the cornerstone immune suppression nowadays is tacrolimus based. And the cost-effective and economic evaluation of different immune suppression agents in kidney transplantation revealed that, according to the National Health Service, the best and the most economic is to use tacrolimus and the mycophenolic acid-based line of treatment. Regarding mTOR inhibitors, as you see, the peak use was in early 2000s, and then their use diminished until nowadays. This is the percentage at time of transplantation, around 2%, and less than 5% in adults kidney transplant recipient are maintained on mTOR inhibitors. In pediatric, this is situation at time of transplantation, and after 1 year, less than 5% are treated with mTOR inhibitors. And this is the same Renal Association VAX guidelines. It stated that there is suggestion that kidney transplant recipient who are able to tolerate tacrolimus or who suffers serious adverse reactions related to its use be considered for use of second-line agents. So mTOR inhibitors, sirolimus or everolimus, and even cyclosporin are considered nowadays as within the second line of maintenance immune suppression. How to monitor? The trough level is available everywhere, and in our center we use trough level for tacrolimus, cyclosporin, everolimus, and sirolimus. And this is a state. All these drugs are monitored with trough level. And cyclosporin can be monitored either by trough level C0 or 2 hour post dose. And the utility of mycophenolic acid is still uncertain, while although I am a little bit convinced by the necessity of monitoring level. Regarding pharmacokinetics, drug interaction and monitoring of calcium inhibitors, the problem of tacrolimus is in its pharmacokinetics, and tacrolimus developed an immense research how to deliver it according to different diseases and different organ, and all these are methods for experimental methods and research methods for delivering strategies of tacrolimus. And this is in liver transplant patients using sublingual route for administration. It's very exciting because it bypasses the first pass metabolism, and it can be suitable for patients with problems like lung transplant or whatever. And since 8 years or 9 years, I wrote a protocol, although it was not conducted, to test sublingual tacrolimus in renal transplantation. And there is some data about its use in renal transplantation in few number of patients. The merit of sublingual route is there is cost reduction, but the challenge is we don't have form of tacrolimus which is best fitting for sublingual. So it seems that if it is reproducible in many studies, that we can find a suitable form of sublingual tacrolimus in transplantation. But still, this is in the beginning. Regarding the measuring the level, the traditional is to measure the level with a venous blood sample, and it is invasive and need the patient to go to the laboratory. But monitoring tacrolimus level, cyclosporin level within a dried blood spot, it's very exciting, because a sample of a drop taken through finger prick at home can be even sent to the laboratory by mail, and this gives flexibility to the patients. Measuring tacrolimus within saliva, it is very non-invasive, and unstimulated saliva sample obtained after mouth rinsing proved to be more suitable than other sample collection method, as shown in this small number study. In a multivariate analysis, the most important predictor of tacrolimus concentration in saliva were the tacrolimus concentration in the blood. This means that using the testing of tacrolimus within oral fluids in the saliva can be a predictor, non-invasive method predicting tacrolimus in the blood. The most important is to measure tacrolimus within lymphocytes, because this is the target of action. And if we know a method that deliver tacrolimus only inside the lymphocytes, this will be very nice. But here we measure the level within the lymphocyte. The authors address this issue through obtaining by density gradient centrifugation peripheral blood molecular cells, and using magnetic negative selection to select in purity, high purity TCD4 and the BCD19 cells. And the authors developed validated methods for tacrolimus quantification within the lymphocytes. And as you see, the accuracy is very high in the peripheral blood molecular cells, in TCD4 cells, in BCD19 cells. And the most important advantage of following the level of lymphocyte, which is a reflection of the action of the drug, because we will be confident in the action of the drug if we can measure it inside the lymphocyte. Here, look here. Solid circles, as you see, the trough level is accepted because this is the current level from 4 to 8 in the maintenance level. So the whole blood is fine, but the level within the lymphocyte is below the therapeutic one. So if we succeed to measure tacrolimus level within the lymphocyte, this will be advantageous for proper refinement of the drug. Regarding the flexibility, the issue of flexibility of tacrolimus. Tacrolimus usually we measure trough level. This means before receiving the second dose or 12 hours after the first dose. It is very rigid. But this study addresses the extended release form of tacrolimus, which is given once daily. And in this study, they assessed the pharmacokinetics of different tacrolimus formulations used in the Astakov trial study. This is 3B pharmacokinetic study that directly compare immediate release tacrolimus or extended release tacrolimus or delayed release tacrolimus. And this study the authors validated a method of not 12-hour post dose. It is here in the long-acting or delayed release 24-hour. This is the trough level. Here 21 and 27, 3 hours before or 3 hour after receiving extended release tacrolimus, and this is the equation that should be done to correct the level, and they found this is very valid and give flexibility for the patient. Regarding pharmacogenetics, pharmacogenetic is one of the very nice ways is to know the genetic makeup of the patients regarding metabolism, absorption, etc. And when we know the criteria of the patient, we can prescribe the best dose for the best patient. And this is for individualized medicine or precision medicine. This is a very large cohort of patients, kidney allograft recipients, 1,923 patients, and they validated the functional variants of cytochrome B3, A4, and A5, and they validated it. And if we know the genetics, this may help. But the problem is the complexity of the issue. Like this one of the studies, this study addresses cytochrome B3A genotypes of donors, but not that those of recipient increase the risk of acute rejection renal transplant recipients on calcineurin inhibitor. And this pilot study included 137 patients, and they found that these two genetic polymorphism were associated with problem, and this genetic polymorphism were related to donor, not to the recipient. So this adds a complexity. Another way is to find a way for population pharmacokinetic model to refine, to apply by this method to estimate individual pharmacokinetics from limited number of sample, allowing the calculation of area under curve, and to individualize the dose in a transplant patient given a set of observation and covariates, including genotype for cytochrome B3A5, corticosteroids, hematocrites, and several tools are available. So this is a way to refine the how to use the drug. Regarding variability, intra-patient variability, intra-patient variability is bad. In this study that included 39,000 level of the drug of tacrolimus, and here, as you see, in comparison to the non-African American, African American with high variability are associated with high rejection, and both non-African American and African American with high variability are associated with graft loss. So variability is bad. Regarding the impact of age on pharmacokinetics, is there a difference between aged person and the young one? This study addresses longitudinal pharmacokinetics of tacrolimus in elderly above 65 with younger patients in the 30s in the first 6 months after renal transplantation. And this study, this is the number of patients including elderly 44 and in the young adults 31 years. As you see, black bar refer to elderly and gray to the young. And this is the dose achieving therapeutic level here, and this is the days after transplantation. All through follow-up period, the old patients need smaller dose to achieve the same level as the young achieves. So this means that we should be meticulous within treating elderly patients to monitor the proper dose, because they may need a smaller dose in comparison to the young one. Regarding pediatric, is there a difference in dealing with pediatric? This study is very nice and illustrates the importance of how to use the drug in pediatric age, and the transition from pediatric to adulthood is very important, because the onset of puberty, as reflected by bone maturation, is the main determinant of pediatric tacrolimus disposition, with stable dose requirement before, the onset of puberty and important decrease thereafter. So it seems that the metabolism of the drug is reduced after the reaching the puberty in pediatric, and they may need larger dose in the young age and a little bit lower dose after that. The most important message is to be cautious in treating patients and monitor their level well. Regarding the exposure and time, so we should be careful because lower tacrolimus exposure and time in therapeutic range increase the risk of de novo DSA in the first year of kidney transplantation. This study included, after testing for DSA, here de novo DSA developed in 117 patients and no DSA, de novo DSA in 421 patients. The lower the level, the higher the odds ratio for developing de novo DSA. And as you see here, the lower the level, the higher the here the mean tacrolimus is between 0 to 3.9. Here, this is the percentage of de novo DSA free. It is lower. This means that DSA is there. So we should keep the tacrolimus level within a good window. What's meant by high tacrolimus clearance as shown from this study? The high tacrolimus clearance is to divide the dose in milligram by trough level in microgram per liter or nanogram per ml. If it exceeds 1.5, this means high clearance. And high clearance is associated with biopsy-proven acute rejection. And within this article, you can find the low, average, high, very high clearance. The higher the clearance of tacrolimus, the higher the risk for rejection. And this should be put in mind. Regarding variability, again and again, variability is bad because high variability is associated with rejection. High variability is associated with lower kidney function. This is high variability. Here the GFR is low all through these times after transplantation. In comparison to low variability, estimated GFR is better. And even percent of allograft survival is affected by high variability. And here, as you see, this is independent predictor of graft failure is associated with high tacrolimus variability. So we should be cautious in monitoring the patients. And the most important is to monitor the patient for serial follow-up, because it is not only one time at 8 weeks, for example, that can represent tacrolimus clearance. We should measure clearance on different time points. One of interesting point regarding the generics, generic immune suppressive drugs here in our center at Urology and Nephrology Center, Mansoura University, the use of generic drugs in transplantation is not accepted because we are not trusting generic immune suppressive drugs in general. Here, this study shows that this type of tacrolimus, generic tacrolimus Hexal, that is produced by Sandoz, was proven to be the same in pharmacokinetics like the original one Prograf. And here, this is the pharmacokinetics testing, and as you see, they are typical. But we cannot extrapolate the finding of Tac-Hexal to other generic, because Tac-Hexal is the only one of many generic tacrolimus formulation to be to show the same pharmacokinetic like the original one. Maybe because of Sandoz, a company with a long history in transplantation and experience in drug formulation. So again and again, we should be cautious with the use of generic tacrolimus, and there are public concerns will likely remain despite the significant market penetration of generic tacrolimus around the world. Although bioequivalence trials in healthy volunteers have proven to provide safe and effective generic formulation, other generic tacrolimus manufacturers should consider evaluating each tacrolimus formulation in the target population to continue address public concern. And this is the rule with tacrolimus and other immune suppressive drugs. Regarding drug interaction, here this is an example. Anti-hepatitis C virus, that is antiviral agents, on graft function and immune suppressive drug levels in kidney transplant recipient, a call to attention in the midterm follow-up in a single center cohort study. This is very nice because even after treatment, this is the curve for the tacrolimus level, and this bar system reflects, columns reflect the dose. Here within the first 4 weeks, there is a reduction in the blood level that instead increasing the dose, and even after the effect, the end of therapy, still the patient needs a larger dose. So it's not restricted only to the time of treatment, and we should be careful even within a year of treatment. Why? Maybe because in drug interaction between direct antiviral and calcineurin inhibitors, or may be due to the recovery from hepatitis and clearance of hepatitis C, so the metabolism may be improved. So close monitoring immune suppressive drug level should be maintained not only during treatment within the course of anti-hepatitis C, but also at least over the first year after the end of therapy to promptly detect relevant deviation in such patients. And this is for tacrolimus, cyclosporin, and even mTORi inhibitors. Regarding the guidelines that was released on September 2017 regarding the viral hepatitis treatment and update, as you see, this is a very smart way. Here, for example, cyclosporin and tacrolimus interaction was different direct antiviral drugs. So cyclosporin increases sofosbuvir by 4 to 4.5 fold, and area under curve, and increase, and so the no prior dose adjustment. In tacrolimus, there is no interaction observed and no priori dose adjustment. Here in this drug, there is this drug, the fold is increased 5.8 fold with cyclosporin. Increase in cyclosporin area under curve. Modeling suggests using 1/5 of cyclosporin dose during pro-D treatment. Monitor cyclosporin level and titrate cyclosporin dose as needed. So this drug increases cyclosporin, and sofosbuvir is increased by cyclosporin. And this is another interesting, because elbasvir grazoprevir combination, this is a very interesting combination. Here, if cyclosporin used, there is increase, 15-fold increase in grazoprevir area under curve, and 2-fold in the elbasvir. So the combination of elbasvir and grazoprevir with cyclosporin is not recommended. So this is a very smart heat map. If you find a red color, this means that this combination shouldn't be given together. Green color means it's nice to be used. And this is a heat map. If you find a green color, this means no problem in the combination. Red color means this combination should be prohibited. So you can go to one by one, and these are the different immune suppressive drugs, not restricted to calcineurin inhibitors and mTORi inhibitors, and the different direct antiviral drugs. Don't forget, green color means no problem. Red color means that it is prohibited. So it is very nice. Even for this drug, this is another example of drug interaction. Nilotinib, which is, can be used as second-line treatment in chronic myeloid leukemia, which is resistant to imatinib. There is interaction between tacrolimus and this drug. As you see here, the use of nilotinib was associated with high level that necessitated lowering the dose and careful lowering the dose of tacrolimus and the careful monitoring of the blood level. One of the most important exciting issue is to look at the pharmacodynamics and immunological monitoring of the drugs, because when calcineurin inhibitor to give its action, it gives its action through reducing nuclear factor, inhibiting nuclear factor of activated T lymphocyte. So by measuring nuclear factor of activating lymphocyte gene expression, it's very important, and regulated gene expression is very important because it will improve the method of treatment. So this study addresses this issue of improved pulse wave velocity reflecting the cardiovascular stiffness and the renal function in individualized calcineurin inhibitor treatment by immunomonitoring, the randomized controlled calcineurin inhibitor sparing trial. This is a very nice study and done in Germany, and this is a new immunological monitoring, as I mentioned, new immunological tool which assesses the expression of nuclear factor of activated T cell regulated gene, measures the functional effect of cyclosporin. So this is a study of cyclosporin based. As you see here, this is the different level, and this is the nuclear factor of activated T gene expression, regulated gene expression or measurement. And the patient were treated either on a standard protocol by measuring level or by measuring the nuclear factor of activated T regulated gene measurement. And in the interventional way, we needed to be between 15 to 30% of the baseline. And here, this is, as you see, the vascular pulsed wave velocity is reduced with the using immune monitoring. This means that it is associated with better cardiovascular status. And here, infection is less, significantly less, if we follow the immunological monitoring by nuclear factor of activated T regulated gene expression. And not only the infection, but also the metabolic, like diabetes, hyperlipidemia, and hyperuricemia, is significantly reduced in an investigational way. And this is very nice and unique and elite to monitor the efficacy. Although it is conducted with cyclosporin in the study, we need to see the immune monitoring with the Tacrolimus, which is the backbone of treatment. And this is the letter, the commentary on the article, mitigating risk of immune suppression by immune monitoring. Are we there? And the answer is, the important finding reported in this trial are that the use of the nuclear factor of activated T regulated gene expression, directed dosing of cyclosporin, averted the development of opportunistic infections, and despite lower cyclosporin level, there were fewer rejections, because we depend upon the effect of the drug on the lymphocytes. No opportunistic infections and improvement in the vascular status. Are we at the point of using this method of nuclear factor of activated T regulated gene expression in routine clinical practice for dosing cyclosporin? Unfortunately, this is not the case. The target of 15 to 30% of this nuclear factor of activated T regulated gene expression also needs to be correlated with age and relative senescence as transplant recipients get older with reduced immune responses. Cyclosporin, this is a problem in this study. Why they used cyclosporin? Because the mostly used nowadays calcineurin inhibitor is Tacrolimus. So I am hoping to find a study on Tacrolimus, although there is some referring data to show the preliminary data showing the same benefit in Tacrolimus treated patients. Regarding diabetes, this is the study in Japan. As you see, the cumulative probability of post-transplant diabetes was lowest with low TAC trough with MMF in comparison to high TAC with MMF or high TAC without MMF. Regarding the empagliflozin and the tacrolimus, this is a very nice experimental study showed that the tacrolimus increases sodium glucose cotransporter expression, and is associated with smaller islets. If you look at the pancreatic islet size here in comparison to vehicle, the use of tacrolimus is associated with significant reduction in the size of pancreatic islets. That is ameliorated by the use of empagliflozin, which is sodium glucose cotransporter 2 inhibitor. So it seems that diabetes is mediated through this issue, and this just to show the effect on insulin, and increases the apoptosis by caspase positive. Regarding the practical one study, this is a very nice study, included large number of patients here and this is the patients were subcategorized according to the different immune suppression protocol. Here, for example, TAC and mycophenolic acid in 84,000 patients, and you can find different combination: cyclosporin mycophenolic acid, TAC mycophenolic acid, sirolimus and cyclosporin, sirolimus and TAC. So these are the different immune suppressive medication, and you can go to the viral serology: hepatitis B, hepatitis C, CMV, Epstein-Barr var. So the question of this study: is there a link between the serology or immune suppression and diabetes? So new onset diabetes after kidney transplantation, can the risk be modified by choosing immune suppression regimen based on pre-transplant viral serology? And if we look at the results, this is the risk factor for new onset diabetes in the year after kidney transplantation. So this is the hazard ratio you can find here. The standard reference drug is tacrolimus mycophenolic acid, and not on steroid, and negative serology. As you see, tacrolimus and sirolimus, this combination is associated with higher hazards of diabetes, and the same hepatitis C is associated and the CMV are associated with higher hazards risk of diabetes. Risk factors for new onset diabetes in hepatitis C and CMV serology cohorts on different immune suppressive regimen is shown in this study. As you see here, sirolimus and tacrolimus is bad, and as in hepatitis C, antibody negative. So the immune suppression here is associated with a higher diabetogenicity. And here this is the most important: cyclosporin and the mycophenolic acid in either HCV negative or positive. The use of this combination is associated with lower risk of diabetes. And this is regarding the different immune suppression in CMV positive or CMV negative patients. And this is regarding graft loss. So graft loss is increased in sirolimus and the mycophenolic acid in comparison to tacrolimus and the mycophenolic acid. Here, this is in hepatitis C, and this is in the immune suppression. So again, in kidney transplant recipients with hepatitis C or CMV serology, sirolimus TAC was associated with higher risk of new onset diabetes relative to the reference, which is tacrolimus MMF in mycophenolic acid in absence of viral serology. And new onset diabetes after transplantation graft loss was lower with TAC mycophenolic acid than other regimens. So tailoring the immune suppression regimen based on hepatitis C or CMV serology may modify the risk of developing diabetes after kidney transplantation. There's another factor, which is hypomagnesemia. Hypomagnesemia can lead to mitochondrial dysfunction. Calcineurin inhibitors like tacrolimus can lead to mitochondrial dysfunction. Another way, hypomagnesemia is associated with insulin resistance, and tacrolimus also is associated with hypermagnesuria and magnesium wasting. This is a very nice study, although it included a small number of patients. The patients in the present 12 months multi-center investigator-driven prospective randomized study was designed to assess whether conversion from tacrolimus to cyclosporin A can reverse post-transplant diabetes after transplantation. So patients were randomized to either replacement of tacrolimus with cyclosporin or continuing on tacrolimus after stratification for the type of glucose-lowering therapy. The study showed that the conversion to cyclosporin is beneficial to reduce the need for antidiabetic drugs and reducing the incidence of diabetes after this shift. One of the production of the our clinical pharmacy unit at the Urology and Nephrology Center is the drug interactions, because here, as you see, cyclosporin increases the level of ribaglinide, and this can lead to hypoglycemia. And the glipizide increases cyclosporin trough level, so it may lead to cyclosporin toxicity. Galobride also can be associated with cyclosporin toxicity. So we should be careful about the use of different immune suppressive drugs and anti-hyperglycemic drug. Regarding hypertension, the mechanisms of calcineurin inhibitors induced hypertension include either the direct effect on the blood vessels, vasoconstriction, or modulating the renal function, and this is through renin-angiotensin-aldosterone system, endothelin, thromboxane, increasing TGF-beta, and reducing nitric oxide, or handling tubular function like sodium chloride cotransporter stimulation within the distal convoluted tubule, and reducing sodium hydrogen exchanger. And all these can lead to retention of sodium and hypertension, or through nephrotoxicity can lead to hypertension. So this is the mechanism of calcineurin inhibitor-induced hypertension. One of the important study, experimental study in mice, is if we can increase regulatory T cell and suppress interleukin 17, this can inhibit and prevent calcineurin inhibitor-induced hypertension in mice. This was another interesting way. Regarding clinical, this is a nice case report, showed that tacrolimus can be indulged in acute heart failure as observed by Doppler, so after renal transplantation. Here, this is as you see, the right side dilatation and tricuspid regurg, and everything is refined after a reduction of tacrolimus. So we should put this in mind. If we have a case of heart failure unexplained, the drug may be under this issue and to be refined. Another issue, this is a pericardial effusion, as you see from this echocardiogram, and this is early tamponading, because here this is the early diastolic collapse of the free atrial wall. And the cause of pericardial effusion in transplantation is very interesting, because a multitude of causes can lead to pericardial effusion, including infections, immunological, and even tumor. So we should suppose the patient to thorough investigation, and at the end, if we don't find the cause may be in the drug. So the immune suppressive, the tacrolimus in this case, was incriminated in the causation of pericardial effusion that resolved completely after shifting to cyclosporin. So this is a tacrolimus as a rare cause of pericardial effusion. Regarding Balint syndrome, this is a case in lung transplantation. Here, ocular dysfunction presenting in tacrolimus-induced posterior reversible encephalopathy syndrome. So the patient presents with optic ataxia, ocular apraxia, and difficulty. So all these all the problems in the eye should raise our attention toward the reversible encephalopathy, posterior reversible encephalopathy, and MRI can show the high intensity signal within the posterior segment of the brain. So this is the reversible encephalopathy syndrome in a lung transplant patient. Although in this case, the doctors cannot decide to continue tacrolimus, but rehabilitation of the patient made a big difference in the management. So prompt diagnosis and treating the patient with the rehabilitation measurements improve the ocular manifestation. Even tacrolimus can lead to cerebral vasoconstriction, and this is the case of 15-year-old girl with reversible cerebrovascular constriction induced by tacrolimus. And if we are aware of this, this patient presents with generalized seizures, and if we document vasoconstriction, we can add vasodilator for treatment of this case. So it is necessary to put all these in our mind. Regarding nephrotoxicity, nephrotoxicity is a very bad issue of calcineurin inhibitors, and this is a thorn in the side of the use of calcineurin inhibitors in renal transplantation, is nephrotoxicity. So this is one of the studies addressing the mechanisms. So the renal epithelial cell senescence was evident by the use of cyclosporin. And tacrolimus and sirolimus, both tacrolimus and sirolimus, were not associated with cellular senescence. So this may explain the effect of cyclosporin. Mechanism of cyclosporin nephrotoxicity are either acute or chronic. And as you see here, these are the mechanism either affecting the blood flow or through these mediators, growth factor beta. This will lead to the chronic toxicity. Aldosterone and aldosterone receptor stimulation can be indulged in the vasoconstriction, fibrosis, and inflammation as shown in this slide. And the use of mineralocorticoid receptor antagonist may help to inhibit all the pathophysiological mechanism incriminated. One of the most interesting and exciting is, if we have tubular dysfunction after kidney transplantation, can we discriminate between nephrotoxicity related to calcineurin inhibitors and others? In this study, they used Facin-1, which is released from proximal tubular cells in urine in response to calcineurin inhibitors, and correlated well with isometric vacuolization in kidney transplant patient. Why they selected isometric vacuolization? Because it is the standard for the calcineurin inhibitor in renal damage. It is the salient features, isometric vacuolization. As you see, Facin-1 in urine is highly correlated here in comparison to other kidney dysfunction with CKD or others. So again, it may be Facin-1 may be a way for a biomarker for calcineurin inhibitor nephrotoxicity. Other way, a genetic polymorphism in the FOXP3 may help a lot in determining the patient receiving cyclosporin based as a biomarker. As you see, this genotype polymorphism is associated with lower estimated GFR TT in comparison to CT and the CC. Another way is to targeting the metabolomic analysis by addressing 33 amino acids. All these biomarkers like the metric dimethyl arginine and the serine can be used, and the area under curve is very nice for tacrolimus nephrotoxicity. Tweak FN14 pathway. This is the TNF weak inducer of apoptosis, can be used, and here even recombinant tweak can be indulged. So recombinant tweak is associated with nephrotoxicity and augments the nephrotoxicity. So the histological score here, if we use both of them, this is tweak and this is cyclosporin. Both of them, either the tweak or cyclosporin, are associated with histological score damage, and both of them have additive effect. So we may target tweak for changing this problem. The microRNA, another biological method to testing and alerts expression of renal microRNA, new insights into calcineurin inhibitor nephrotoxicity, and this is how they are expressed. Either blue color means low and high, and you can find different expression of microRNA in the control versus cyclosporin treated. And this is the another study showing that if we can define microRNA messenger RNA interaction map for calcineurin induced nephrotoxicity, this will be very nice. With this, This is arterial cyanosis, as you see. This is arterial cyanosis that can be one of the side effects and one of the nephrotoxicity of tacrolimus or calcineurin inhibitors. And it is unique because it affects the media. So it is medial nodular cyanosis and starting from the adventitial side and affecting the media. But the problem is, and this is another the same, the problem is it specific 100%? The answer is not specific 100% because we may find arterial cyanosis without the use even of calcium inhibitor at all. This is a very interesting study, and it raised alarm and red flag because renal allograft histology at 10 years after transplantation in tacrolimus era, evidence of pervasive means prevalent chronic injury. In this study, surveillance allograft biopsies were assessed at implantation, time for transplantation, 5 years and 10 years, for 145 patients. If we look here, this is baseline, 5 years, 10 years. If you look, this is the white color means none, the gray one means mild, and the black one means moderate severe. The arterial cyanosis increasing with the within the advancement of the years. Mesangial sclerosis, global sclerosis, tubular atrophy, vascular chronic changes, and transplant glomerulopathy are increasing. Although in this category of patients who lived for more than 10 years, the antibody restriction was not there. So it may be the transplant glomerulopathy here is related to non-immunological factors. This is why we should be aware of non-immunological and addressing them earlier to refine and to improve the outcome, because within the year there is increasing the chronicity that is correlated with kidney function and proteinuria. So we need to know well how to deal with our patients and to improve the immunology and non-immunological damage. Regarding electrolyte disturbance, in comparison to mTORi inhibitors, calcineurin inhibitors, the hypokalemia is more prevalent with mTORi inhibitors and less with calcium inhibitors, and the calcium inhibitors are associated more with hyperkalemia because the calcium inhibitor stimulates sodium chloride co-transporter within the distal convoluted tubule and reducing sodium delivery to the distal nephron, leading to hyperkalemia and reducing potassium secretion, because potassium secretion within distal nephron is dependent on sodium reaching this segment. And one important point also is increasing chloride reabsorption, and the presence of negative chloride is negative. If it is present with the lumen, it stimulates potassium secretion. So increasing chloride reabsorption after the use of calcium inhibitor increases as well hyperkalemia. So this is a case series of hyperkalemia and renal tubular acidosis. Regarding special issues, bone pain, the calcium inhibitors can cause persistent disabling foot pain in kidney transplant recipient. In this case, the immune suppression protocol includes cyclosporin, everolimus, and steroid. And here the bone pain improved completely, and bone marrow edema improved after shifting to mycophenolic acid. So the guidelines regarding the bone pain induced by calcium inhibitors, induced bone pain, reduction with or withdrawal of calcium inhibitors, and we may use calcium channel blocker, dihydropyridine calcium channel blocker, because the hypothesis under the etiology of calcium inhibitor induced bone pain is vasoconstriction. So calcium inhibitors increases bone vessel vasoconstriction. So giving calcium channel blocker may ameliorate the case. At the end, we may even shift to other drugs. What's the effect of vitamin D? This is a very nice study showing that the use of vitamin D suppresses bad cytokines like interleukin 17 and interleukin 22, and these are the beneficial effects of vitamin D in transplantation. Regarding the PK, the tacrolimus is associated with PK as shown in this study, and this is the difference between tacrolimus and cyclosporin. So tacrolimus, this is free of PK virus. So here tacrolimus, although there is no difference in viremia, but there is a major difference in biopsy-proven PK virus nephropathy. Although tacrolimus is more potent to reduce rejection, but we are afraid of PK virus. If you have a patient who is suffering from tremors and you need to continue tacrolimus, how to deal with this patient? This is a case of tremors, and after reduction of tacrolimus, the patient suffered from rejection that necessitated increasing the dose of tacrolimus, and tremors was distressing. So the only solution for this issue is how to keep tacrolimus within therapeutic level and to get rid of tremors is by shifting it to slowly release or extended release tacrolimus, because tremors may correlate with the immediate release peak level. So, and this is the guideline suggesting slow release tacrolimus may be used as an option, a second line agent for patients who suffer intolerable side effects related to peak dose toxicity. And one of the peak dose toxicity is tremors. Regarding mTORi inhibitors, this is in a very rapid. I'm going just to highlight some studies. So this is one of the studies, early conversion to prednisone everolimus as an alternative weaning regimen associated with beneficial renal transplant histology and function, the randomized controlled Meccano trial. In this randomized controlled open label multi-center trial with early cyclosporin elimination, patients started with basiliximab, prednisolone, mycophenolate, mofetil, mycophenolate sodium, and cyclosporin. At 6 months, immune suppression was tapered to prednisone cyclosporin or prednisolone mycophenolic or prednisolone everolimus. So the trial continued with prednisone cyclosporin in 89 cases and prednisolone everolimus in 96 cases. Interstitial fibrosis and inflammation were significantly decreased, and estimated GFR was significantly higher in prednisolone everolimus patients. Another study addressing the question, if early conversion to mTORi inhibitor represent a suitable choice in renal transplant recipient, a systematic review of medium-term outcomes. If we look at this systematic review, the main results, the mTORi inhibitors are more favorable due to their complementary mechanism of action and favorable nephrotoxicity profile, better GFR, and lower serum creatinine with equivalent survival. However, higher rejection rate may influence the use of these regimens in patients with moderate to high immunological risk. And this is a very important caution. Another systematic review and systematic meta-analysis assessing the short-term applicability of early conversion to mammalian target of rapamycin inhibitors is the same as you see regarding GFR and creatinine. It is superior to shift to mTORi inhibitors. But again, rejection is bad because rejection is higher within the use of shifting to mTORi inhibitor and is lower in calcineurin inhibitor treated. So early calcineurin inhibitor withdrawal seems to be more pragmatic approach, as it bestows to give or to provide better renal function in the low immunological risk renal transplant recipient. So again, low immunological risk. Again and again, up to this moment, this is one of the systematic review, including 83 studies involving 16,000 participants, again, to withdraw calcineurin inhibitor and to be replaced with mTORi inhibitor. Still, the evidence is not strong. Still, we are afraid of rejection. Let us go to this study, which is a recent study. A total of 194 patients were planned to be randomized 1-to-1 to either continue tacrolimus or to convert to everolimus at the month 3 after transplantation. At randomization, all patients received tacrolimus, mycophenolic mofetil, and prednisolone. The trial was stopped. Prematurely after the inclusion of 60 patients. Why? Because of high rejection, unacceptable high rejection rate in the everolimus group compared with the control group, 30 versus 6 something percent. An additional 8 patients stopped everolimus because of toxicity. And the conclusion of this study, conversion from tacrolimus to everolimus-based immunosuppression with withdrawal of prednisolone 3 months after kidney transplantation results in unacceptably high risk of acute rejection and causes considerable toxicity. Based on this finding, such a switch strategy cannot be recommended. So we should be cautious about these points. And again, higher rejection. The 3C study, Campath calcineurin inhibitor reduction and the chronic alveolar nephropathy study. This study is a pragmatic randomized control trial of sequential randomization between alemtuzumab and basiliximab induction therapy at the time of surgery, and between tacrolimus and sirolimus maintenance therapy at 6 months post-transplantation. Compared with tacrolimus-based therapy, sirolimus-based maintenance therapy is associated with higher rejection. So biopsy-proven rejection is higher with everolimus. But we are expecting that it's fine to have some increase in rejection, but to keep kidney function better. The more striking is no difference in kidney function. So sirolimus-based maintenance therapy didn't improve transplant function at 18 months after conversion and was associated with significant hazards of rejection. So this is against conversion. Even in transform study, the effect of everolimus with reduced exposure calcineurin inhibitor. This another scenario is to keep calcineurin inhibitor within low window and to add the everolimus. And we are waiting the results of this study. But the initial results showed no difference in kidney function. We are waiting. How to use mTORi inhibitor? This is one of the important review article that shows how to use these drugs. The most important is to read the relative contraindications: interstitial lung disease, obesity exceeding 35 kilogram per square meter, primary focal segmental glomerulosclerosis and original kidney disease or atypical hemolytic uremic syndrome, complex vascular anomalies or high energetic risk. All these are relative contraindication for the use of mTORi inhibitors in transplantation. And this is how we handle both drugs. When we use everolimus with cyclosporin, the starting everolimus dose is 0.7 twice daily. But if we use with tacrolimus, the starting dose is 1.5 every 12 hours, because cyclosporin inhibits the metabolism of everolimus. That is not the case with tacrolimus. And the most simple issue is to keep everolimus and tacrolimus together to the sum of 10. So in early transplantation, we don't like high level of everolimus, so keeping it 3 to 4, and tacrolimus 6 to 7, and after that, on the long term, to switch tacrolimus to around 3 to 4 and sirolimus to 6 to 7, to keep always some 10. And this is how to deal if we have pneumonitis and delayed wound healing after treating the patient with mTORi inhibitor, or lymphocyte or proteinuria. This is, if we read proteinuria together, our policy, if we have persistent proteinuria above 1 gram, we stop mTORi inhibitors. But here, as you see, if it is less than 1 gram, maintain and combine renin-angiotensin aldosterone system inhibitors, RAS blockade, between 1 to 3 grams, reduce the dose to the level around 4 and continue RAS. And if it is above 2 and 3,000 gram, biopsy and discontinue. But if we have persistent proteinuria above 1 gram, our tradition is to discontinue. There is assumption that the mTOR inhibitors have anti-cancer, and this is through the modulation of mTOR and the proliferation. So this is the proposed mechanisms of anti-cancer. But the best way is to, as shown in the guidelines, they suggested that mTOR inhibitors have specific anti-tumor effects in Kaposi sarcoma, and this is our policy. when the patient suffers from cutaneous Kaposi sarcoma, we stop the calcineurin inhibitors and to be replaced with mTOR inhibitors. And at present, there is insufficient evidence for primary use of mTOR inhibitors as protective against most of the cancer types. Regarding hypertrophy, this is a very nice review showing that mTOR inhibitor suppresses left ventricular hypertrophy or reduces left ventricular hypertrophy through anti-proliferative mechanism. However, this study, the cardiovascular parameters 2 years after kidney transplantation, following early switch to Tacrolimus without calcium inhibitor therapy, an analysis of randomized elevated study shows that after 2 years, there is no significant difference in hypertrophy and left ventricular muscle index between everolimus and the calcium inhibitor. So we are waiting another evidence. Regarding atherogenesis, it was shown that mTOR inhibitors have unique anti-atherosclerotic effects, such as depletion of plaque macrophages, induction of autophagy, and activation of cholesterol efflux. However, the use of these drugs is associated with dyslipidemia. So it seems that, and it is known as mTOR inhibitor paradox, it seems that it is beneficial to use the class and plus treating the dyslipidemia with statins. Regarding diabetes, this is the mechanisms. mTOR inhibitors either working on the islet cell through reducing insulin release from the islets, or on the peripheral cells to target the insulin action and leading to the diabetes by different mechanisms. So mTOR inhibitors are associated with post-transplant diabetes either by affecting islets or the peripheral cells. Regarding viral infection, and this is a very interesting review about the role of mTOR inhibitors in the management of viral infection. A review of current literature, as shown in this review, there is high quality of evidence supporting that mTOR inhibitors is beneficial in the use of mTOR inhibitor is associated with lower percentage of CMV. So de novo and the early conversion to mTOR inhibitors significantly reduces the risk of developing CMV. This risk reduction continues with or without the addition of calcineurin inhibitors. More studies are needed before recommending the elimination of CMV prophylaxis without an appropriate preemptive approach in the setting of mTOR inhibitor use. Conversion to mTOR inhibitor for treating CMV, data concerning the clearance of CMV with the use of mTOR inhibitor is limited to case reports, and therefore conclusion cannot be made, and this is low evidence. And the proposed mechanism anti-CMV effect of mTOR inhibitors may be that these are anti-proliferative drugs can also inhibit the proliferation of the virus. Regarding the PK, de novo mTOR inhibitors may reduce the incidence of PK. This is a moderate evidence. Conversion to mTOR inhibitors in patients with PK viral nephropathy may reduce PK virus. This is low evidence. Data concerning the clearance of PK virus viremia in patients without PK viral nephropathy with the use of mTOR inhibitor is limited and conflicting. Regarding HCV, de novo mTOR inhibitors or conversion to mTOR inhibitors may slow the progression of fibrosis in hepatitis C virus infection. mTOR inhibitors don't appear to influence hepatitis C viral load, and their correlations with Epstein virus, HHV8, Epstein virus is low with mTOR, and HHV8 is moderate. mTOR inhibitors appear to have benefit in the treatment of HHV8 associated Kaposi sarcoma and HIV low evidence. So these are the quality of evidence supporting the conclusion of affection of viruses by mTOR inhibitors. And this is a meta-analysis showing that mTOR inhibitor plus reduce the dose calcium inhibitor versus a regular dose calcium inhibitor plus mycophenolic acid and azathioprine is associated with significant reduction of CMV and insignificant PK virus. Transform study that included 2,000 patients showed, this is the initial results, viral infection is significantly lower in the everolimus in comparison to mycophenolic acid drugs. CMV is lower, and here the PK, so it seems that there is advantages of the use of mTOR inhibitors regarding the viral infection. A very interesting case is lymphocyte and lymphedema after kidney, after allograft biopsy. Lymphedema in the skin of the all of us are aware by lymphocyte and the lymphedema, but here this is a very nice case because it involves the kidney in patient treated with sirolimus. Lymphatic damage caused by kidney needle biopsy may be a responsible factor for this complication. This case report has shown that lymphedema of the transplanted kidney can involve the adjacent abdominal wall and they become associated with an ipsilateral pleural effusion. Therefore, transplant clinicians should be made aware of this unusual complication of mTOR inhibitor therapy to prevent unnecessary and expensive investigation and to allow for decision to be taken regarding discontinuing sirolimus immune suppression in this case. So again, this is the regarding the fertility and ovarian side effects. There is high incidence of ovarian cysts in women receiving mTOR inhibitors after renal transplantation, as shown in this study. And this is the histopathology of ovarian cysts, simple cysts, serous cyst adenoma, etc. So we should be aware of this issue. And regarding the contraception, we don't allow the mTOR inhibitors for females who are planning for pregnancy, and they should be stopped 12 weeks in advance, and the patients continued in contraceptive methods. Regarding men, kidney transplant recipients should be advised that mTOR inhibitor reduce the male sperm count and counseling accordingly. And men on mTOR inhibitors who wish to conceive should discontinue, not only women but also men, this agent prior to conception and replace them as appropriate. Men who wish to maintain fertility should avoid mTOR inhibitor or bank sperm prior to starting these drugs. So we should put this in our mind when we select the drugs. Just to conclude this presentation, it is very important, crucial to use tacrolimus and how to know how to use the tacrolimus in transplantation. We developed our experience, so with the starting days we used larger doses and targeting a higher level, so we witnessed a lot of complication. Nowadays we are enjoying the use of tacrolimus because we understand how to use it properly. One of the most important points is drug adherence, and we should educate all patients, physicians, nurses about the value of drug adherence. And this is the cover of the issue of March of the American Journal of Transplantation. And within this issue, you can read the FDA public meeting on patient-focused drug development and medication adherence in solid organ transplant patients. And these are points, transplantation specific factors for medication non-adherence, either socioeconomic, related to younger patients, male gender, non-white, non-US resident, poor social support, poor transportation, literacy, or medication complex medical regimen, higher medication toxicity, lack of medication education, no pill reminder system, patient-related history of non-adherence, adolescence, psychological disorders, depression, cognitive impairment, psychological substance abuse, negative beliefs about medication, high symptom distress, development of new onset diabetes, for example, here I mentioned, because so when we tailor immune suppression and select immune suppression, we should put the patient-centeredness approach in our mind, because all the side effects, the patients are afraid of all side effects of the drugs. So we should educate the patients, and we put a plan how to predict and how to treat the complications and the healthcare system. So all letters A refer to modifiable factors to improve drug adherence. If we apply to tacrolimus, does shifting it from immediate release to slowly released tacrolimus will help and improve the adherence? So this is a study, immune suppression adherence in stable kidney transplant patients converted from immediate to prolonged release tacrolimus in clinical practice, a Norwegian study. The answer is use of this extended release will help to improve the adherence within the first months, and after that, no difference. So there is the shifting from immediate release to sustained release or extended release is not the solution for improving drug adherence. And these are the minimal practical guidelines in which to build successful adherence intervention in adolescent transplant recipients. So you can fix this slide and read all the lines. So through this presentation, I went through different pharmacokinetic side effects, some trials of calcineurin inhibitors and mTORi inhibitors, and I restricted the data to all publications within 2017 and 2018, and hoping you the best. And if you have any question, please don't hesitate to send it to my email. And goodbye. Thank you very much.